Hi, I'm Gerard Finnessy from the Victorian Intensive Care Network. The following podcast was recorded at our September 2014 meeting. Is there a doctor on the plane? In part 1 of this entertaining talk, Dr Ian Hosegood, Medical Director of QANTAS Airways, discusses the aviation environment, the epidemiology of in-flight medical emergencies, and the causes and costs of most common medical diversions.
Thanks for having me. So look, I think the plan is, so we don't have you sort of sat there staring at me for too long, is to do sort of half the talk, have a bit of a break, and then we'll do the second half. And if I've got a big chunk of rocket in my teeth, please tell me, because it feels like I have. So I'll see if I can drive this. Not. Yes. Okay, so this is my bio. I thought I'd do pictures. I'm a simple guy, so I go with pictures. My background's Air Force originally, did about 12 years in the Royal Australian Air Force. That's where I did my aviation medicine training, where I learned AvMed, went to the UK and did the diploma in aviation medicine through at Farnborough. During my time there, did a few UN deployments, including some time as a weapons inspector in Iraq and some other interesting jobs like that. And then got out of the Air Force, and because it was time to kind of drive a desk at that point, which I wasn't interested in, I went to Emirates, where I was the aviation medicine specialist at Emirates Airlines, and then eventually was the vice president of the medical services, so heading up the clinical medical services for Emirates Airlines, which has a huge medical department of about 150 people, 25 docs, so it's pretty full on. It does all the primary care as well as the occupational and aviation medicine. Came back to Australia to head up the medical department at CASA, so I was the principal medical officer at CASA. And then had a few years as the General Manager Health Services of the RFDS up in Queensland, so working back in retrieval medicine and also primary health care. And then the last couple of years I've been the Group Medical Director with Qantas Group, so it includes Jetstar as well as the sort of non-wholly owned subsidiary airlines as well in age. So all up we've got about 9 airlines in the group. And my background is general practice, the FACASM and the FRACMA and the FRACGP. Not critical care, so don't ask me any complicated critical care questions tonight. This is where I work. My building's right on the airfield. Our clinic's in there at the moment. Got a very small team. Used to be a massive team with nurses all around the country, but like most corporate medical departments, it's shrunk. And we really just now provide a lot of oversight, advisory, policy, standards, and some complex clinical caseload with the aviation medicine and other issues. So our main sort of areas of coverage are passenger health, which we're talking about today, the drug and alcohol program for the aviation industry, occupational health, and also sort of travel medicine, health and wellbeing, that sort of corporate health, occupational health type stuff. And what I'm going to talk about, so as I said, we're going to split it in two. A little bit about, briefly, 101 aviation medicine, just to remind us all. A bit about what happens in the air, in-flight medical emergencies. A bit about medical diversions themselves, the costs and what we see as the causes. And then we'll have a bit of a break and we'll talk about what we kind of do about all this stuff. What can we do? Cabin crew training, policies, the involvement of medically qualified volunteers on board, and equipment and medicines as well. So, we'll kick on. Why might the aviation industry sort of be interested in medical emergencies, and what might be some of the background causes? First of all, obviously the personal issues. We've got people getting on board with all these sorts of issues, pre-existing illness, they're anxious, they've forgotten their medication, they've left it in the hold, they've taken medication they wouldn't normally otherwise take, particularly we have a lot of issues with the admixture of sleeping tablets and alcohol. We've got an increasingly ageing population. Flying's getting cheaper, more accessible, and we're getting better at looking after ageing people. So we've got a lot more older people travelling now as well. And then the airport itself can be quite stressful. And we've also got a whole bunch of factors that are specifically related to aviation itself. So obviously cabin altitude, reduced oxygen tension, pressure changes, immobility, low humidity, vibration fatigue, and obviously jet lag, circadian dysrhythmia. So a whole bunch of reasons why we may see in-flight medical emergencies, both because the people have brought their illnesses on board or also because they've been exposed to some physiological challenges as well. So this is a bit of a scary-looking slide, but it really is just an attempt to kind of capture what we do in the aviation industry is called bow tie, where we look at a top event and we look at the precursors to an event and we look at the management or mitigation of event after it's happened. So a bow tie is a way of looking at what you can do in between each of these and where you can place controls to either prevent the in-flight medical emergency happening or to mitigate the outcome of the in-flight medical emergency. And obviously from our perspective, as well as the health outcomes, we're also interested in the medical legal issues, the significant costs, and of course the operational disruption, because that costs us a lot of money. So we look at it in a kind of a holistic manner. A bow tie is a way of looking at that. And we'll come back to this a little later on. So a bit about the altitude pressure environment. So you know, we'd like to think that we're all travelling in this sort of environment. Unfortunately, it's usually a lot more like this. And you know, the realities, you all heard about our profit announcement this week, in inverted commas. So the reality of life in the industry is that the profit margin's about 1% if you're lucky. So you've got to make $100 to pocket $1. But if you can save $1, that's $1 straight in your pocket, right? So it's really marginal, and slight increases in fuel and other issues can really push you over the edge. So more and more, we're packing more people in. We're trying to get clever about the way we do it, but we're not quite back to this stage where you had to bring your own oxygen. These are great. I love this old photo because apparently this is not only for conversing with each other. You have the gap there. It's also so they could smoke. Which is great. All right, so a bit about the conditioning system. So I won't go into too much detail. Just as I'm sure you know, there's about half fresh air. So it's air that comes in through the engine, gets compressed in the engine, and gets bled off. So it comes in very hot and under pressure. It gets cooled down. It goes into a mixing chamber where it's mixed with about 50% recirculated air. So air that comes from within the cabin goes through a HEPA filter, and then that gets mixed together and then pumped into the cabin. And the way that the actual cabin pressure is controlled is through this outflow valve. So this valve is about the size of a window. Sometimes it's fully open. And, you know, it sort of goes to the point of where you see these movies where someone shoots the window out and everyone gets sucked out. That's just not the case at all. I mean, the 777, for example, can lose a window and still maintain absolute pressurisation because the inflow is just so great. And they would close this outflow valve and control issues. So the other point of note, as well as the fact that it's recirculated air, the pilots have a separate supply. The air goes sort of a beam ship. It doesn't go fore and aft, and that's always of interest to us in terms of communicable diseases on board, and when we look at following index cases that have travelled, SARS and things like that, not Ebola, where we see that it's the rows in front and behind that are affected by TB, SARS, and it's usually a long exposure. And people are far more likely to contract it in the waiting lounge or somewhere else than they are on board the aircraft. We have a very high flow rate. But of course, the higher the flow rate, the lower the humidity, because the air coming from the outside is cold and dry. And this is the kind of typical pressurisation system. The way it works is we've got about an 8.6 psi differential between the outside and the inside. So that's the maximum it can withstand. For that reason, the aircraft's quite heavy, and with newer, lighter composite materials, because the aircraft's lighter, they can get the same sort of strength with a much lighter aircraft. They can now have a lower cabin altitude. So you'll see that the 787, for example, has got a cabin altitude of around 5,000 feet now, which is a really positive step forward. If we applied the 8.6 psi right from the get-go, so 15 psi is the same as 1 atmosphere essentially, you would stay at sea level until you hit this point where the pressure differential is hit, and you would then get a rapid rise in the cabin as the aircraft altitude rose. But what we do is the aircraft computer system works out the smoothest change, and it works out the destination altitude, the origin altitude, and works out the smoothest pathway. So if your destination altitude's La Paz, where it's 14,000 feet, for example, it'll actually go the other way. The cabin altitude will go down to 6,000 or 8,000 feet and come back up on landing to meet the destination altitude. So they're very clever little computer systems. But the key takeaway is the aircraft might be at 35 to 41. The cabin's around somewhere between 5,000 and 8,000 feet. So we get this sort of profile where this is what the airplane's doing and this is what the cabin's doing, and it's a very small part of the envelope that the cabin's operating in so that we can be in essentially physiological conditions for healthy, younger people. And A reminder, the other thing, does anyone remember which law it is that the volume-pressure relationship? Pardon? Laplace? No, that's the one about the skin getting thinner as the bubble gets bigger. Boyle's law, yeah, excellent. So pressure, that's good for a bunch of intensivists. I'm glad that you knew that one. So it's pressure, inverse relationship between pressure and volume, right? At a constant temperature. And the important thing, the other part of it is that water vapour pressure gets taken out if you're talking about saturated spaces like sinuses and ears and gut. So it's got water vapour pressure, so that magnifies the effect. So at 6,000 to 8,000 feet, we're looking at a 30 to 40% increase in volume of any trapped gas or any semi-closed space gas. So it's a pretty significant increase. So that's the other issue, as well as the volume change. We've also got the issue of hypoxia, obviously. And just a reminder again, that essentially we've got this sort of nice exponential curve in the hemoglobin saturation curve. What we normally think of this is thinking about this as being the kind of tissues where we're releasing all the oxygen, and this being the lungs where we're trying to hang on to the oxygen with the hemoglobin. If you think about it from an altitude perspective, you can see that at the aircraft is sort of at this point is just about on the slippery slope, the slippery part of the slope where it's going to suddenly get a whole lot worse because of the nature of the curve. So we can maintain stats up to low 90s at the 6,000 to 8,000 feet, but if we go much higher than that, we're going to get into tiger territory. Hence the cabin. And if we look down the bottom here, we've got the sort of equivalent oxygen requirement for the cabin altitude. We see that we need about 29% oxygen to maintain sea level saturations. Or to talk about the other way, it's the equivalent of breathing about 14 or 15% oxygen. And I'm sure many of you involved in high altitude simulation tests to test people pre-flight to make sure people with complex respiratory illnesses are okay to travel. And the other thing to remember is that at altitude we will hyperventilate, and by hyperventilating and driving down a CO2, we'll shift the curve to the left. And so we'll again get some compensation, and our saturations may be maintained even though the PaO2 is getting precariously low. So that's important, for example, in interpreting pulse oximetry on board the aircraft. You may still have a reasonable saturation, but your PaO2 could be extremely low. And this is just looking at the effect of age in healthy population based on a study by Mike Moom from Boeing. So it's got to be taken a little bit with a dose of salts, because Boeing obviously designed this aircraft, the 787, to have a cabin altitude at 5,000 feet. But what he showed was that as you go up sort of every 10 years, you're getting an increasing percentage of the population that at that cabin altitude will have a PaO2 of less than 50. So what you can see, for example, in a 65-year-old is the predicted percentage of the population with a PaO2 of less than 50 is around 45%. So pretty significant. And so people are really on the precarious edge, and if they've got any cardiopulmonary compromise, that can push them over the edge. So a little bit about, as I said, a little bit about what happens on board. So there's quite a few numbers here, which I won't go through in detail, but just to pick out a few, that basically a few of these papers that have been pretty reproducible over the years have said that essentially in-flight medical incidents occur from around 1 in 40,000 passengers to 1 in 11,000 passengers. So it depends on how you report it. If you report every headache, cough, cold, obviously your numbers are going to be very significant. Most people don't do that. They're not aware of it. They don't count them. So we're talking about more significant types of events. And vasovagals are quoted at anywhere between 22 to 37% of the incidents that occur in flight that are reported. So this is something that's been deemed worthy of reporting. And we find that the other thing of note is that if we look at ground-to-air type studies, so the Dijon study and in the NEJM last year, we find that we're getting sort of numbers like 8 per million enplanements of incidents that have been deemed significant enough to call your ground-based medical support. So we're pretty uncommon sorts of events that we're talking about. And as you can see, even of those ones which are more significant, about 26% ended up at hospital, and of those, 8% admitted, and a very small number died. So we're seeing that in-flight medical incidents, whilst we sometimes get the perception of very, very common, more serious in-flight incidents are pretty uncommon, in fact. And very serious incidents are less common still, and I'll show you some information around that. So we benchmark ourselves. So we're with a group called MedAir, which some of you may or may not have heard of. They're telemedicine, ground-based support. They do 24/7 calls for all our in-flight stuff. So the cabin and pilots will call MedAir for advice. And if there's a doctor involved, they will also potentially speak to MedAir as well. So MedAir have got all of our call data, and we benchmark ourselves against like-type carriers. So we generally perform pretty well. We're in the sort of 10 to 25th percentile for our in-flight medical incidents, which we like to think reflects our pre-flight screening, which we'll talk about a little later on. And then around diversions, if we look at so we talked about incidents, now we're talking about more serious incidents that lead to diversions. And we see the numbers are more like 210 per million flights, or 1 in every sort of 4,500 flights that we might end up with a medical diversion. 7.9% of all of their incidents resulted in diversion, and reproducibly, all of the studies are showing that chest pain, cardiac, neurological, generally seizure or stroke or suspected stroke, and then to a lesser degree GIT and syncope and trauma. Trauma is normally turbulent, so we get a clear air turbulence. Someone hits the roof, or the trolley lands on someone, or they have some sort of spinal injury. Those are a lesser cause of diversions. Yeah, it's not good. So the clear air turbulence is where you've got nothing on the weather radar and you're flying along, and then suddenly you just have this pocket of pressure where the aircraft essentially drops out of the sky. So when it drops, everything else goes up, and if it's not tied down, and that's why we're always encouraging people to wear their seatbelts when they're not walking around, because we do see some pretty serious events each year. There are always deaths, and generally the cabin crew are the most likely to be injured. Again, Dijon, 13% of the in-flight medical incidents, 1 in 1 million passengers carried. And again, cardiac, neurological, vasovagal and respiratory creeping in there. And importantly, and what we see is a very similar pattern, there's about 19%, we think about 25%, were probably unnecessary in the light of what comes to light. Quite often they get back on the same flight. They'll go and get seen by the airport medical department. We get a call saying, can we clear them back to continue on the flight, even though we just diverted the aircraft into Nandi or somewhere like that to get them cared for. Or quite often it's the next day. So we do see a lot of unnecessary diversions. And again, the Peterson study, which has looked at just under 12,000 incidents, or 1 in 604 flights, 7.3% of those ended up in a diversion. So again, we're seeing quite small numbers of diversions, and it's interesting. We're interested in whether there's more impact from the person, the nature of the person themselves, or is it the impact of spending a long time on our aircraft? So one of the studies we asked MedAir to do was to look at the correlation between RPKs, which are revenue passenger kilometres. That's the number of kilometres somebody is travelling on. It's an exposure measure essentially of the number of heartbeats on our aircraft versus the number of passengers carried. So this is per individual. And we found that the correlation is much better for the individual. So what we think that means is that it's more likely you're bringing your condition on board than we are worsening your condition, so to speak. So it's more likely the state of health of the person getting on board rather than the exposure, particularly exposure time, to the aircraft. And when we look at the timing of incidents, they don't all end up at the end of the flight. We don't find that this long exposure on ultra long haul flights, for example, leads to a big spike in incidents at the end of the flight. It tends to be something that's going to happen. It's that person, and it's just that window of risk that we're exposed to. And this is some IATA data. So as well as the MedAir data, which looks at all their customer data, this is IATA data. And IATA is kind of the airlines representative, the airlines union internationally. And they every year gather all the data from the big players in, and it's about 24. Whoops, I don't know what I did then. Try that again. 24 airlines involved in that study each year, and we look at all sorts of things like AED use, diversions, deaths. And what you can see here is that the diversion rate very, very low. So we're talking about diversions per billion revenue passenger kilometres, and the death rate also per billion passenger kilometre extremely low. We're also seeing a positive trend in the diversion rate, and this probably is related to the implementation of improved travel clearance guidelines and also the use of telemedicine support, as well as potentially an impact from medical telemetry, which we'll talk about a little later on as well. And again, we benchmark ourselves versus the other carriers, and we find that Qantas performs pretty well, which makes us feel good. But we obviously are always trying to improve our statistics, because this is one that obviously the airline management is very interested in. We'll talk about cost of diversions in a minute, so you'll see why it gets their attention. So making a diversion decision, so this may be your diversion airfield. You may be the doctor on board, right? And you're in this situation, and the pilot says to you, "What do we do, Doc? You know, where are we going to go? What are your considerations? What do you think the considerations might be about whether to divert or not, and where to divert?" So I'll throw it back at you guys. Yeah, you're going to get them to a higher level of care, which is always one of the principles of aeromedical retrieval, as well as, are you actually going to get them somewhere you can help them? Is that a centre? What's the nature of their condition? Is there a centre that's going to actually improve their condition? What else? If you've got a couple of options you're choosing between. Time's obviously a factor, isn't it? What else might be a factor, as well as the health issues? Big clue there. Obviously, the suitability of the airfield. So what generally will happen? So we've got obviously medical urgency, the time consideration, and importantly, it's time to definitive care, not time to land. So if you go, I just want to get somewhere quickly, the pilot will get you somewhere quickly. You've got to say, actually, well, hang on a minute, that's now got a 50-minute drive through traffic to get to the closest hospital, as opposed to this one, which is a half an hour flight further, but was actually right next to a major tertiary centre right next to the airfield. So it's about time to definitive care, and most airports these days do not have anything resembling definitive care, if anything, at the airport. The characteristics of the destinations, obviously, from an operational risk, the navigation aids, the air traffic, the ground handling. The pilot's going to push back hard if you're going to ask him to land somewhere like this. And I'll show you an example in a minute of one of the classics. Obviously, you're going to talk to the captain in great detail, and generally he will give you his operational options, which you'll then liaise with Medlink, who will tell you from their database what the medical options are. So it depends on where you are in the world. Pilot will tell you the options. Medlink will put in their database and go, this one's got a burns unit, this one's got neurosurgery, whatever, and this is the time to get there. And that's how we do it. And so, for example, if you're doing an ultra-long range flight over the North Pole, which is very, very common these days with the new ultra-long range aircraft, the A340-500 and the 777LR, these things fly for sectors of up to 24 hours and in one hit. And so the quickest way, for example, from Singapore to Los Angeles is straight over the pole, from Dubai to San Francisco, straight over the pole. And your options for diversions in this region are pretty few and far between, and you may be 2 to 3 hours from any one of these. And the other thing is you may not have comms because you lose communications over the pole. So an example would be Longyearbyen as one of your better options. And I in a proving flight for an A330, we went up there and I was doing some cosmic radiation measurements of all things, but we actually did a low-level flight over Longyearbyen because it was one of our alternates, just to have a look at it. And there's the runway there, and this is the town of Longyearbyen in here. And there are actually 2 doctors in town, and there's this little clinic. The hotels in town can accommodate about 30 or 40 people. So if you get an A380 going in there, also that's a frozen fjord. So there's no apron, there's no way to turn the aircraft about. They've got to fly a ferry aircraft in there and tow it back and take it to bits, basically, to get it out of there. So they don't want to go there. But sometimes, you have to. If it's a mechanical diversion, not a medical diversion, there's no choice, right? So, and there's been some pretty famous Arctic and Antarctic diversions where, the cost has been up to $1 million, basically, because of all those reasons.
How many intensive care beds does it have?
0.
Not a good place to work, then.
It'd be a challenging place to work. Never a dull moment. Well, actually, there probably would be several dull moments there. All right, so looking at the cost itself, it's hard to say there's a number. Everyone goes, what's the cost? What's the cost? Really, it ranges pretty significantly. If we have what we call a gas and go, so you're literally just landing, offloading the person, you gas up a bit, and then off you go again. It might be a 20, 30 grand for a domestic diversion, as an example, if it doesn't have any impact on anyone else. But if you start looking at all these other factors down here, You know, if you have to dump a lot of fuel, if you've got to pay landing fees, you've got to have all the ambulance and hospital fees, which often come back to us. Missed connections, accommodate people. The crew might come out of hours. They can't finish the rest of the flight, so you've got to fly an extra crew. It disrupts the whole network, has a knock-on effect. We're pretty quickly getting up into the hundreds of thousands of dollars. So for an A380 diversion with accommodation for the passengers, so we have several of those every year, and quite often they're in Honolulu or New Caledonia or something like that, because the Trans-Pacific is the really diversion-poor route for us. We're talking about $300,000, $400,000 quite often per diversion. So they're not cheap. And I won't go into all of these details, but you'd just be surprised the various knock-on effects that will happen from just one diversion, because your network utilisation is so tight with crew and aircraft that losing one aircraft, particularly if their crew are going to be out of hours, can have a massive impact on the rest of the network. So just to give you a kind of a picture before we have a little break, is it time for a break? Yeah. This would be a typical year for us. Looking at all that industry data, what does that really mean for us as a medical department? As an airline, we carry 20 million passengers, so this is Qantas mainline, not the group. We'd have about 6,000 medical incidents on board that are reported to us, right? So it's one for every 3,000 passengers. We have 30 to 40 diversions per year. We just had one. I had one just a couple of hours ago. It was a Hong Kong-Sydney flight diverted into Brisbane because a guy was cyanotic and unrousable. So we're getting them pretty much one a week or more. We get them they come in spates, of course. We get 2 to 4 deaths on board each year. We've had no births for many, many, many years. Unlike some other carriers, and particularly Middle Eastern carriers, we see. When I was at Emirates, we saw a lot of people that were trying to get home to have the baby for various reasons, which I won't go into, and quite often wearing the abaya in late pregnancy, trying to get home. There were births on board. So Emirates has maybe 5-6 births on board a year, which is pretty challenging. We use our AEDs about 5 to 10 times per year. We get two to 4 of those are probably shockable rhythm. Quite often it's not a shockable rhythm. The person's found in the toilet or in their seat after a long period of time. And we get a much lower rate of shockable rhythms on the aircraft than we do on the ground. For that reason, and we also think because of some other reasons which have got to do with orthostatic pooling and lower circulating volume. So we do get a lower success rate in the air, and it does not seem to be related to technique. It's related to those other issues. And we generally get a couple a year that sort of go off the aircraft breathing and beating under their own steam, and we don't really know their long-term outcomes, of course, because from a privacy perspective we don't have the right to follow through and find out. Sometimes we do find out, but generally speaking, when they're in pretty good shape, I guess we hope for the best. And then we get 5 to 10 uses of what we have the Anapen on board, not the EpiPen, and proper legitimate saves from anaphylaxis on board where people have not got their auto-injector with them for some reason that I never understand. And we probably have 100 and 150 IVs set up. So, there's a fair bit of stuff going on board the aircraft. And I'm sure people in this room have been involved in some in-flight incidents, and if you've got some war stories later, feel very free to share them, as long as they're not a big complaint. We do analyse our data. So this is, for example, one of the analysis from the use of medical kits. So we get our data from various. We get crew reports, we get med-air reports, and we get paperwork and analysis of the use of the kit. So we have to kind of triangulate what's happened on board from all those various sources. So sometimes a diversion will happen and we won't even get a crew report. We'll find out from Medlink or vice versa. So we're always trying to triangulate what's actually happening on board. But we do analyse it and so for example, here's a drill down. Here's the high-level diagnostic group data, and then we'll do a drill down on the neurology and try and find out in detail what's going on board, so that we can then adjust that and feed that back into the crew training and also to the kit that we carry on board the aircraft to make sure it is practical and is fit for purpose, essentially. And so another example of the analysis that we'll do, this is the use of the medical kit, reasons for opening on the left, so down to the individual reasons. Asthma is a very common one because we've got the inhalers in the kit. Because they get nicked if they're anywhere else. And we have a lot of people coming on board without their inhalers and getting into trouble. And this is a list of all of the equipment that's most commonly used on board. And you can see common things occur commonly. You know, we've got a lot of kids' fevers, headaches, nausea and vomiting, all the stuff that just happens quite commonly. And far less commonly, we're seeing the more serious bits and pieces: breathing difficulty, food poisoning, anaphylaxis, death, etc. So, one of the issues we looked at is potentially taking the ventilator inhalers out of the kit, because it does cause a bit of paperwork. And at the moment, whilst we might lose a fair number from pilfering, it'll actually probably save us some money overall in terms of the turnover of the kits themselves, which do have to be turned over for expiry dates anyway. We generally find that the kits are turned over through use before they are turned over through expiry. And we spend a lot of time looking at, obviously, at expiry dates and selecting our medicines very carefully to try and reduce the turnover due to expiry. And most of the kits come back through in a cycle of about 3 months. So one aircraft will generally be used at least every 3 months. And if we look at the diagnostic categories, this is just another view of those categories, but looking at it from a Med-Air, from the Med-Air data, and these are really awful colours because they're kind of replicated the way down. But what we find is that the point of this slide is that this is the stuff that causes the incidents, but when we look at what causes the diversions, and the C is just the benchmark data again, so this is the QANTAS data and this is the benchmark data, what we find is that whilst cardiac causes a very small proportion of the overall incidents that occur, when you look at it from a diversion perspective, they're causing 40 to 50% of the diversions. And as I said earlier, neurological and gastro are the other. If we look at those three together, we're talking about more than 75% of the medical diversions are caught in those three areas. So that's at the moment where we're trying to focus our attention, and we'll talk a little bit later on about the cardiac, what we're trying to do around the cardiac stuff. And I think that's break time. Does that work? Yep. Okay, great.
Thanks, Ian. That's fantastic. Does anyone have any particular questions just now that they'd like to?
You have to quote me on this, but I think we've got 3 adult and 2 paediatric anapens. So, and quite often we then go to the vials afterwards. So an anaphylaxis is generally a diversion, unless it happens close to the destination. So we had one recently. It was in the press where we diverted into Perth. We'd already used 3 pens by the time we got, and still getting back into trouble because, as they do. So we then end up using the vials as well as the auto injectors in some cases to try and get us to the diversion. We haven't had a death yet from anaphylaxis, so far that program's been really successful. So.
I presume there's a standard medical kit amongst all certainly the long-haul flights. Does it apply to the domestic flights as well? That everyone has the same kit, or
we have. You mean Qantas or all airlines? Qantas itself. We've got a few versions of the kit. So we've got a large one for the long haul and a smaller one for the short haul, and we've also got a sort of a get me down for some of the regional stuff. So it's it's got things like Ventolin, GTN, anaphylaxis, the sort of stuff that is needed immediately and urgently, but where you're going to get in somewhere within 15, 20 minutes. So we do tailor it, but we try not to have multiple versions of it. And so we've recently got Jetstar to align with Qantas, for example, and use the same kit. And we're working on, and we're also trying to have commonality with people like Virgin, so that people have used a kit, they're familiar with the same one. We haven't got that yet, but that's one of the issues we're talking about. And we're also trying to get some commonality with other airlines around the world. So we do have, I'm on a thing called the IATA Medical Advisory Group, where we have all the airline medical directors meet, and we do try and align where possible. But for various reasons, political, personal, we can't align everything. Harmonisation is always a challenge. There's a core contents list that ICAO requires, but everybody exceeds that, and then they have their own various ideas. So, for example, one of the things on one of the slides later is which we're going to put misoprostol on for postpartum hemorrhage, just because all the other alternatives are too unstable for us to store on board. But because it's an abortificant, also, then many states would not allow it to be on the aircraft because of the controversies and the politics. So, Emirates would be a good example of someone who wouldn't be able to have it on board. We've got controlled drugs, and S8s and other airlines don't have those at all. So you'll see some variation based on local laws, regulations, preferences. Some have antibiotics on board, some don't. And everyone defends their position vehemently, with data too. Yeah, so any other questions? Yep.
Similar question. QANTAS Easy, English language speaking aircraft, Emirates, other places, Air France, etc. Does everything get labelled in English as well as the native language, similar to how they do their...
Generally, at least 2, and sometimes, if you're in Emirates, for example, I think they've got it labelled with 3 languages, so they've got French, English and Arabic, obviously. So, but that's it. It won't go much further than that. They won't have multiple language interpretations, but generally speaking, we're lucky in that English tends to be one that's common across the board. It's getting a little bit easier now, so one of the things we're looking at, for example, is we've got a booklet in the medical kit that you open up and it's got a quick guide and shows where everything is. And it also leads you through how to manage incidents, so it might be used by a nurse, paramedic, anybody. We are looking at trying to get that on the iPad, and once you get it electronic, you can then have versions in languages and things that it's much easier to deploy than it is in a paper-based process. So.
You've got quite an array of medications, it sounds like, and I assume the probability of having a doctor of some description on any flight is very high. Is there a way that these medications can be administered without a doctor? Or?
There are some of the medications that kind of 3 tiers. So there's the over-the-counter stuff that can be given out pretty freely. There's some authorised medicines that can be given out by the CSM, the senior cabin crew member, with either the agreement of the parent. So, for example, we put that control over children's Panadol. So they've got to brief the parents about the limits and get their agreement, and then they can use it. Adrenaline auto-injectors, the cabin crew can use. There are then some medications that are given by the cabin crew with Med-Air authorisation or an onboard doctor authorisation, and then there are medicines that can only be used with a doctor on board, which is a significant majority of most of the injectables and a lot of the oral medications that we have in the kit.
And what do we know about the doctors that are on board that are responding to these incidents? Is there any data about that?
There is some. There is data, but we haven't ever analysed it. It's a good question. We know that, and I'll put some slide up that sort of talks to that in a minute. We know that we get a very good response rate, so we get around 85% response rate when we ask for a doctor on board. On an A380, sometimes we get 6 doctors respond. We think there's probably 100%. On the long haul, there's probably 100% of flights have a doctor on board. So 85% represents, the people who are willing to own up. Their wife's nudging them saying, go on. Or they've had a couple of gin and tonics and they don't feel comfortable, or they're a psychiatrist, or whatever. But in terms of the craft groups, we've never analysed it. What I can say is that there are doctors and there are doctors. And there's a slide on, without stealing the thunder, I suppose. I think we find that if we get folks like you responding, we get fantastic outcomes. Some other docs, it doesn't go so well. One of my colleagues from a British airline, which will remain nameless, their policy used to be put out a PA for a doctor. So is there a doctor on board the aircraft? And when they put their hand up, you chain them to the back of the aeroplane and then get on with managing the emergency. So, because they kind of get in the way sometimes and forget to put oxygen on and overcomplicate things, and instead of just doing the basics, lie the patient flat, put the oxygen on. It's the stuff that they're sort of trying to do the diagnosis. And so we try and get the cabin crew to do the basics at the very least, and get Medlink to remind them of the basics, because sometimes, and there is some data, that the outcomes are not as good sometimes with doctor involvement. So it's a good question. Paramedics, no, they can't. That needs doctor involvement. So unfortunately, it needs doctor involvement. Yeah, we don't allow paramedics to administer, unfortunately. I mean, there are probably ways that we can, in Australia, we could get around that. Internationally, we would struggle. So it's one of the sort of challenges for us, I think that opens up a lot of opportunity for us. Without stealing the thunder, an example of if something maybe in the future would be pre-hospital thrombolysis on board the aircraft, right? So paramedics can do that. You know, if you're in a situation where you've got trained personnel to do it and you think the environment's right and the risks are all low, maybe it's something in the future that could be considered, particularly when you might be 5 hours from the closest destination. I don't think we're going to go there, but who knows? Drugs might get better and safer. Yeah. So. Pardon? Yeah, that's right. Well, onboard echo, that's right. Yeah, exactly. All right. Well,
Great,
make
thank you.
sense.
Thanks for listening. For more great talks from the Intensive Care Network, go to intensivecarenetwork.com. Thanks for listening. For more great talks from the Intensive Care Network, go to intensivecarenetwork.com.